With modern approaches to gastroduodenal disorders, from two new techniques in evaluating gastroduodenal disease, fiber optic endoscopy and hypotonic duodenography, through choice of operation for peptic ulcer disease, to surgical treatment of cancer of the stomach and sarcoma of the stomach, plus some related abstracts from the current surgical literature, this is Audio Digest Surgery, Volume 17, Number 12, the week of June 24th, 1970. Beginning the program, Harvard Medical School's Paul A. Kantrowitz describes this new technique of evaluating gastric disorders, fiber optic endoscopy.
Endoscopy, of course, has been around for a long time, but in the past decade, the technological advances have been considerable in several directions. One, fiber optic instruments have become generally available, and while these are basically no safer than the older instruments, perhaps because less experienced people tend to use them more readily, they are nonetheless better tolerated by patients, and the improved optics has enabled improved photography to become part of the examination. And very importantly, direct vision biopsy can be done during gastroscopy. The endoscopic procedure is basically the same as it has been in the past, with discussion of the procedure with the patient, premedication with sedative and antispasmodic drugs, topical anesthesia of the mouth and hypopharynx, and then introduction of the instrument in either the sitting or left lateral decubitus position. The angulus is identified and serves as a landmark for the rest of the examination, which includes antrum, pylorus, body, and with retroflexion of the instrument, visualization of the cardia and fundus, and this is a new addition to the examination. The examination should not be performed in patients who are uncooperative, confused, or comatose, and also should not be done in patients with acute cardiac disease or delirium tremens. Some of the older complications like cervical osteoarthritis are no longer a problem because of the flexibility of the instruments. We have used two of the Olympus gastroscopes. These are Japanese instruments, and the biopsy gastroscope illustrates rather dramatically the extent to which the thing is flexible. Deflectable tip facilitates examination of the entire stomach, and also the biopsy forceps is inserted right through the instrument and exits within the visual field of the scope, so that one can biopsy, view the biopsy site, and also photograph it to verify it. The camera attaches to the proximal end of the instrument. I'd like to discuss three of the applications of the combined use of X-ray and fiber endoscopy, which we've had experience with. First is in the problem of the patients with upper GI bleeding, and we, like at many other large municipal hospitals, see a great deal of this. From our point of view in evaluating patients with bleeding, there are several problems that come up. One is to distinguish between potential and actual bleeding lesions. For example, an X-ray that demonstrates varices or a duodenal ulcer, to know when to infer that the lesion that's demonstrated is actually the bleeding lesion, and when to decide to proceed further and try to visualize the site of active bleeding. Two, another problem, the differentiation between or among multiple potential bleeding lesions. The alcoholic who comes in with liver disease, esophageal varices, a scarred duodenal bulb, and a recent binge of alcohol, who could have variceal bleeding, could have duodenal ulcer bleeding, or could have acute gastric mucosal bleeding. Finally, the problem of the patient with bleeding who comes in and has a normal upper GI series. How to proceed with such a patient. And it's our experience that in these situations, endoscopy at the time of active bleeding is crucial. That is, when the diagnosis is uncertain on clinical or radiographic grounds, or in particular, when esophageal varices are suspect or known to be present, since the therapy for variceal hemorrhage is both highly specific, medically or surgically, and also quite hazardous, medically or surgically. And the automatic assumption, as in the earlier literature, that all patients with varices and upper GI bleeding are in fact bleeding from those varices is not borne out by our recent experience, where a minority of such patients with varices actually, when esophagoscoped and gastroscoped at the time of bleeding, are found to have variceal hemorrhage. We've often been able to visualize an esophagus that's free of blood during active bleeding, and at subsequent gastroscopy just right afterward, see an active bleeding source, such as these gastric mucosal lesions within the stomach. So that the two values of endoscopy in patients with bleeding are, one, recognition of the actual bleeding site, and two, detection of these superficial mucosal erosions or acute gastric mucosal lesions or hemorrhagic gastritis, etc. These, I might say, constitute the source of bleeding in about 25% of our bleeding patients, perhaps due to the high incidence of alcohol and aspirin in our patients, and these figures are also borne out from studies reported from other institutions. Now, obviously, in many instances, X-ray is sufficient. If an X-ray study is performed first and discloses a large duodenal or gastric ulcer or a malignant lesion, it may be unnecessary to perform endoscopy. Moreover, X-ray is the only technique that's widely used that demonstrates duodenal ulcer disease. So that these studies are complementary and are both very important. Each has specific value, each has limitation, and I've already indicated the instances where we feel endoscopy is important, but this does not mean that we automatically approach every bleeder in the same way, and indeed many patients require just a careful clinical assessment and an upper GI series. Next, some of the instances where a combined radiographic endoscopic approach has been very helpful to us in the management of patients with gastric mass lesions. In the differentiation of mucosal from submucosal lesions, the fundus is an area of the stomach that has been difficult to evaluate in the past. However, fiber optic endoscopy can be helpful here. The differentiation between carcinoma and lymphoma may be important in terms of prognosis and therapy. The evaluation of benign versus malignant ulcer may be difficult, and I think it points out the limitations of any technique, and also the importance of biopsy as an adjunct to the endoscopic procedure. Finally, in evaluation of mass lesions, both X-ray and endoscopy may be helpful in following patients with polyps. A final use of this combined radiographic and endoscopic technique is in the evaluation of the postoperative stomach, which is difficult to evaluate, and where endoscopy can aid in the evaluation of the remnant, the stoma, and the jejunum.
One question, Dr. Kantrowitz. Do you believe gastroscopy should ever be done before doing an upper GI series?
We individualize our patients. I would say that I never gastroscope without a prior upper GI series or prior esophagoscopy. Since the esophagoscope is passed under direct vision, the gastroscope is passed blind, and one can avoid problems of diverticular strictures and the like by viewing the esophagus first. We do esophagoscope and gastroscope before X-ray if there's a question of varices, and if we wonder if the varices are the source of bleeding, or if we strongly suspect these gastric mucosal lesions. If we suspect gastric ulcer, duodenal ulcer, or cancer, we always X-ray first. If we're in doubt, we X-ray first.
Thank you, Dr. Kantrowitz. Even as a last-ditch measure, gastroscopy is a valuable diagnostic aid in upper GI bleeding, reports W.H. Morse in the American Journal of Gastroenterology. In his experience, 15 patients whose condition couldn't be diagnosed by X-ray or other means had late gastroscopy, 2 to 9 days after an episode presumed to be upper GI bleeding. In 11 cases, a probable cause of bleeding was located. 7 of the 11 showed hemorrhagic gastritis, an almost impossible diagnosis to make by X-ray. 2 patients had marginal ulcers, also difficult to diagnose by X-ray because of the disarray of rugal folds in the anastomotic area. And the other 2 patients had gastric ulcers, one probably filled with clot, thus subverting X-ray diagnosis, and the other a linear ulcer, probably stress-induced and hardly subject to the usual X-ray criteria for ulcer diagnosis. As for the 4 undiagnosed cases, the author speculates, they might represent bleeding beyond the pylorus, an area usually impenetrable to gastroscopy. For greater diagnostic accuracy, the author urges earlier resort to gastroscopy. It was 93% accurate when used early in one study of 1,400 patients and produced minimal complications, only 2 cases of perforation, in another group of 7,800 patients. Turning now to the evaluation of duodenal disease, Jack Wittenberg of Harvard Medical School and the Boston University School of Medicine summarizes experience with hypotonic duodenography in evaluating the GI tract. Let's listen.
Since the endoscopist's peep show is limited by the pylorus, diagnoses in the gastrointestinal tract beyond this point rely much more heavily on the techniques of the radiologist. And in response to this, we have developed arteriography now to define actual bleeding sites within the duodenum and to diagnose the occasional obscure small bowel tumor. And certainly, isotopic scanning, the newer techniques of scanning, have helped to work out problems in the pancreas and the liver. Hypotonic duodenography is another of the newer developments. Hypotonic duodenography is a method of studying the duodenum during a short period of drug-induced relaxation. The examination is actually begun by the passage of a special nasogastric tube, a polyethylene radiopaque tube that has side holes, no end hole, and the cable fits within it. The tube is passed into the stomach, and then the cable is inserted, and with this unit we can manipulate into the antrum quite easily and then catheterize the duodenum, usually within 3 to 5 minutes. Once this is accomplished, the cable is removed and the tube is retracted, and usually we place it at the end of the second duodenum because in most cases we're interested in defining the anatomy at this point. The tubeless method is essentially using gravity and then some built-in air, if there is air in the stomach. I've used that when I've been unable to catheterize the duodenum and have gotten good results, but not quite as often as with the tube. I think it's a good method if you can't actually get right there with the tube. Once we have the tube positioned, the anticholinergic agent is given. We usually use probanthine. The dose varies from 30 to 60 milligrams depending on the patient's weight. After about 5 minutes, the duodenum is relaxed and the examination can be done. The barium is delivered through the tube and spot films are taken of the barium filling and then an air contrast stage. And the films that result are really analogous to the kind of films you're used to seeing in the air contrast barium enema. The examination lasts for approximately 45 minutes in the routine cases. Now, hypotonic duodenography has enabled us to control the distensibility and motility of the duodenum and really has added a great advantage over the conventional study. We have really, with the experience in these last couple of years, begun to appreciate a little easier the normal radiographic anatomy. A right angle kind of shoulder effect is an important landmark because it helps to define the area of the papilla vata. This has been called the promontory by Ferrucci and is seen in about 60% of his cases. And then the papilla's frenulum. That's the normal duodenum. Some of the pathologic entities that we have seen recently, the mass lesion in the duodenum, the annular constricting lesion, and unilateral abnormalities. You're going to see more of this technique. It's really helped us a great deal by getting rid of the peristalsis and enabling us to distend the stomach and the duodenum, and in fact the colon. I think we're being able to define anatomy much better and therefore pathologic conditions occurring in there.
Dr. Wittenberg, what are the major complications of and contraindications to hypotonic duodenography?
We have done about 50 to 75 in the last 2 years and really haven't had a major complication. The patients have a dry mouth and sometimes they have blurry vision for several hours, but that goes away. In other large series, the most major complication has been urinary retention, and we've tried to avoid that in our technique by just restricting fluid intake, having them void prior to the procedure and restricting the fluid afterwards for about 6 hours. The contraindication, I ask people about glaucoma because I'm worried about precipitating glaucoma. My friends in ophthalmology say not to worry about it. I think the major contraindication is a patient with a arrhythmia, and I haven't yet, but I'm afraid that I may precipitate something like PAT and get him in trouble cardiovascular-wise. We haven't yet.
Thank you, Dr. Wittenberg. The lack of any unanimity of opinion among surgeons as to the best surgical treatment of duodenal ulcer is a very clear indication that the ideal operation has yet to be described. Our next guest speaker, Douglas A. Farmer of Yale University School of Medicine, provides some guidelines for today in making a choice of operation for peptic ulcer disease. Dr. Farmer?
The three major surgical procedures currently popular are subtotal gastrectomy, usually in an extent of about 65 to 75%, and partial gastrectomy and vagotomy. And when I say partial gastrectomy, this includes a lot of different terms: hemigastrectomy, antral resection, distal gastrectomy, conservative gastrectomy. They all mean approximately the same thing. And finally, the third type of maneuver, of course, is the vagotomy with the emptying maneuver. Now, the three major considerations influencing choice of operation are the incidence of recurrence, that is, the ability of the operation selected to negate the ulcer diathesis; two, the incidence of unpleasant post-gastrectomy side effects; and three, and of course of paramount importance, what is the mortality rate of the procedure you're going to do. Insofar as recurrence rate is concerned, the most attractive scientific method of suiting an operation to an individual would be on the basis of gastric secretion. If two things are known, namely, what's the minimum amount to which acidity must be reduced to afford lasting protection, and two, what will any individual operation do to any individual patient in terms of reduction of acidity, knowing these two facts, then the least extensive procedure could be selected for that individual patient. If performed with care, certain tests of gastric secretion are reasonably accurate and reproducible. The insulin test does have certain advantages in postoperative evaluation. We concluded that any operation which is to protect indefinitely against recurrence, the operation must alter the patient's secretory apparatus in such a way that the pH can't drop below 3.5 at one time or another during basal insulin testing. Now, the comparative results of the three operations studied in terms of whether or not the operations did maintain a pH above 3.5 on postoperative basal insulin testing. A considerably higher percentage of the hemigastrectomy group had this desirable elevation of pH when compared with the subtotal group and with the vagotomy and the emptying maneuver. Now, the fact that this is a reasonably valid concept is suggested by examining the recurrence rate in these individuals. The recurrence rate following hemigastrectomy and vagotomy is considerably lower than the others, and it's pretty much in keeping with the recurrence rate that is generally reported in the literature, plus or minus 1% by most of the people who have been interested in this operation. The subtotal gastrectomies were of a moderate magnitude. Some of the earlier ones were the radical 75 to 80% ones, and if they had all been 75 to 80%, the recurrence rate for subtotal gastrectomy would probably be lower. But the unpleasant side effects that accompany the very extensive radical resection were one of the reasons that persuaded us to try some of the more moderate resections protected with vagotomy. The recurrence rate for vagotomy and an emptying maneuver agrees with a great many of the ones that are reported in the literature. It's a curious paradox, and to my knowledge unexplained, that some groups present recurrences in the neighborhood of 3.5 to 5 or 6%, while other series present very startling recurrence rates and, if true, unacceptable levels of recurrence. Now, in view of all these figures, it just seems reasonable to suggest that a good many large series are going to have to be followed for a long, long time before we arrive at the true recurrence rate. And until these figures are available, I seriously question the wisdom in adopting this procedure in an unselective fashion for all patients with duodenal ulcer. In general, the extent of resection, the larger the resection, the more prevalent the unpleasant, the distressing post-gastrectomy sequelae. This is certainly true when you compare a radical resection with a very conservative resection, but it's a lot more difficult to detect a real difference between those having an antral resection and those having a pyloroplasty. Logically, you'd expect the person with the intact stomach to have fewer side effects, but it's really hard to detect a real definite percentile difference. Our experience comparing subtotal and partial resection with vagotomy, this refers only to the distressing sequelae such as weight loss, dumping, diarrhea, incapacitation, and so forth, not recurrent ulcers or deaths. There is a slightly larger group of the patients with a more extensive resection fall into the fair and poor category than with the less extensive resection and vagotomy. I haven't put our results with vagotomy and pyloroplasty because we have used this in a very selective method, and it's not exactly fair to include the elderly, the patients that you think are likely to be bad results and whom you've selected for vagotomy and pyloroplasty, and compare them with the others who are unselected. Of the poor results there, the 7% poor results for hemigastrectomy and vagotomy, persistent dumping accounted for 1%, weight loss accounted for 3%, and diarrhea combined with other symptoms accounted for just under 3%. Now, recently, in some circles, there's been enthusiasm for selective vagotomy, that is to say, division of the gastric branches of the anterior and posterior vagi, leaving intact the hepatic and the celiac branches. It had been hoped that this maneuver might reduce post-vagotomy diarrhea. I personally have had too few cases to draw any sound conclusions about it. I still have an open mind. Incomplete vagotomy, incidentally, has not been a problem. In this respect, there have been two recent reappraisal articles in the literature. Both groups of authors, Ferris and Smith out on the coast and Kraft and Fry in Ann Arbor, both groups had originally come out with articles favorable to selective vagotomy. Now, more recently, both have written reappraisals, and they suggest that the differences in the results really don't seem to justify the added work it is to do a selective rather than a truncal vagotomy. Now, the most important single consideration is mortality. As Dragstead so succinctly put it recently, the worst thing that can happen to an ulcer patient is death. And in this respect, without much question, the lesser operation has an edge. The antrectomy vagotomy mortality runs between 1 and 2%, whereas the mortality with vagotomy and an emptying maneuver generally hovers around 1% or less. And the most striking thing about the mortality rate, of course, is massive hemorrhage in the aged. And more important than just age is severe concurrent disease, hepatic, pulmonary, renal, and cardiovascular. These individuals are least able to withstand the stress of surgery and anesthesia, and it's in this group that the least traumatic procedure is indicated. And it's here that despite the incidence of rebleeding, the incidence of late recurrence, that I would think that oversuture of the bleeder, vagotomy, and an emptying procedure is the procedure of choice. Another technical consideration that comes into efforts to reduce mortality rate if one is going to do a resection deals with the pathology in the region of the duodenum and pancreas. And about 1/2 to 1/3 of the mortality rate after resective maneuvers results from stump blowout or pancreatitis or both, and it behooves one who favors resection to explore this area very carefully before resection, and if there's any question in one's mind about the safety of dissection, circumferential dissection of the duodenum, the surgeon should be flexible enough to abandon his attitude about resection and go ahead with a lesser maneuver. And say the most obvious conclusion to be drawn from the foregoing is that it would be a grave error for any surgeon to adopt a rigid and unyielding approach to this problem. Any surgeon should be familiar with the different operative techniques and willing to adapt the operation to the individual patient. In the treatment of duodenal ulcer, there's little indication for the 65 to 75% subtotal gastrectomy. If vagotomy is coupled with gastrectomy, one gains nothing in the incidence of achlorhydria or lesser recurrence rate by extending the resection above the antrum. With certain exceptions, I feel that the procedure of choice is partial gastric resection and vagotomy. After all, one is operating to cure the ulcer, and there's little evidence that any other operation is nearly as effective. However, the mortality is still a major consideration, and anyone who advocates anything beyond vagotomy and an emptying maneuver must be sufficiently flexible that the hazards of age, hemorrhage in an older individual, or in one with significant associated system disease, or a dangerous anatomic situation in the region of the duodenum should readily persuade one to settle for a lesser operation. In the absence of these contraindications, and for those patients whose gastric secretion on testing falls near or above the average values for duodenal ulcer patients, particularly the excessive hypersecretors, the most satisfactory overall results will follow hemigastrectomy and vagotomy. However, if secretion studies show that the basal output is not excessive, and if the response to insulin or augmented histamine is less than that usually seen in duodenal ulcer patients, one might consider vagotomy and an emptying maneuver, particularly if the indication for surgery is intractability.
How effective is distal gastric resection for gastric ulcer, Dr. Farmer?
It's a very effective operation for gastric ulcer, as a matter of fact. And I think particularly if you have a gastric ulcer very high in the lesser curve, if you can get in and biopsy and assure yourself it's not malignant, and just do a distal gastric resection or even a vagotomy and an emptying maneuver, I think it's the ideal way to treat them. Almost anything you do in a gastric ulcer patient in the way of gastrectomy or vagotomy and an emptying maneuver will cure whatever the ulcer diathesis is in a gastric ulcer patient. I stayed away from gastric ulcer because I suspect that it's really not an acid peptic disease as we commonly consider it. Almost all gastric ulcer patients do have acid. It's darn rare. I've only seen one gastric ulcer patient that didn't have a pH below 3.5 on this testing. And it's easy to ablate whatever ulcer diathesis they have in terms of acid. But I do think that the distal gastric resection, without much effort to remove the ulcer if it's a high one, but simply biopsying, is a very effective method of treatment.
Thank you, Dr. Farmer. And this is the end of Side A of your program, Doctor. The continuation of this issue on modern approaches to gastroduodenal disorders can be heard by simply flipping over the cassette or 2 reels on your tape recorder. This is Side B, Audio Digest Surgery, Volume 17, Number 12, continuing a program on modern approaches to gastroduodenal disorders. Most surgeons are reluctant to perform primary gastrectomy for the treatment of acute duodenal perforation, and the preference seems to be temporize with simple closure of the perforation. But George Nemenich and Dmitry Nikolov of Minneapolis find that not only do the peptic ulcer symptoms usually recur, but also that the incidence of postoperative complications and death is quite high. They reviewed the records of 79 patients treated by simple closure and noted that there were 9 postoperative deaths, usually of peritonitis secondary to the perforation. 26 of the 79 patients ultimately required a second operation. Factors that the authors believed influenced this high death rate include age. There's a sharp rise in mortality among those over age 60. Interval between perforation and operation, a delay of more than 12 hours quadrupled the death rate, and the presence of serious concurrent disease, such as emphysema, carcinomatosis, arteriosclerotic or congestive heart failure, and diabetes. Half of those so afflicted died following perforation. Perforations located in the posterior duodenum and those associated with GI bleeding also raised the mortality rate. Even if the simple closure group had included only those less than 60 years of age, with perforations of less than 12 hours duration and without severe concurrent disease, the rate of recurrent symptoms, complications, subsequent operations, and postoperative deaths would still have been high. But if patients selected by these same criteria were treated with a definitive procedure, such as vagotomy and pyloroplasty, they should tolerate it with minimal risk of morbidity and death. 6 patients in the author study had curative surgery initially for their duodenal perforation, and the results were excellent. These authors concede that it would be equally improper to treat all patients with perforated duodenal ulcer with gastric resection or vagotomy and pyloroplasty, because a number of these patients will have no further ulcer symptoms after simple closure. They do stress, though, that with careful selection of patients and an increased initial use of curative surgery, the immediate and long-term mortality and morbidity rates of perforated duodenal ulcer can be further decreased. Although the incidence of cancer of the stomach in men and women is decreasing, its prognosis continues to be very poor, as Harry S. Goldsmith of New York City's Memorial Hospital for Cancer and Allied Diseases explains now in his discussion of cancer of the stomach.
We know that the incidence of cancer, both in the male and the female, is decreasing. Nobody knows the reason why, but it's certainly a fact. It now is not an unknown disease. We see the same number of gastric cancers that you see with people with leukemia, and we know that these patients are present. It's interesting that the Negro population in this country is going down also, but it still has an increased incidence than the white population. I do not know the reason for this, but Dr. Winder at our hospital, who's an epidemiologist, feels that gastric cancer, next to cervical carcinoma, has a direct correlation to a person's socioeconomic status. If you're in the #1 socioeconomic class, you'd have a less of a chance of getting gastric cancer than in the poorer classes. And his feeling is our social economic improvement continues throughout the country. This could be one of the reasons we are seeing a decrease both in this country and throughout the world. Now, as far as diagnosis is concerned, we are becoming much more sophisticated in making the diagnosis. Gastric cytology, or any type of cytology, is improving. Our institution, our cytologists see 150,000 specimens a year. And unquestionably, you become quite adept when you have a great volume in which to interpret. More and more it appears that the cytology people can pick up gastric cancer even quicker than X-ray. They seem to be more exact. Of course, it depends on your cytologist, and of course, it depends on who's harvesting the specimen. If you get a gastric washing and you put it in the windowsill, you probably will never get a very accurate yield in terms of diagnosis. At our institution, we found out that in these patients with proven gastric cancer, the X-ray was correct in 87% of the time. However, there were 13 patients for a total of 11 or 12% who, even with an X-ray diagnosis that was only suspicious or negative, turned out to have a positive cytological diagnosis. So we feel in our hands, cytology can be extremely accurate. Our cytologists feel they can be accurate 98 to 99% of the time. When you take all the modalities, cytology, X-ray, endoscopic evaluation, we should be getting pretty close to the 100%, 99, 100% chance of being able to pick up patients with gastric cancer. It's interesting that Dr. Jordan wrote, gastric cancer is decreasing in incidence, and yet the incidence of gastric ulcer is the same. And so this should even make it easier for us to pick up. But unfortunately, we're not doing a very good job. What we did, we had 270 patients who were studied just between 60 and 64. That's from January 1st to December 31st. So there's a 5-year follow-up until January 1, 1970. And we had the usual range of patients, males, females, the age group, and the usual presenting symptoms that you see in any tabulation of patients with gastric cancer. The thing that's always impressed me is weight loss. We had a man we operated on yesterday who had no other symptoms, but over a 5-month period he's lost 18 pounds, and he had a huge distal gastric lesion which was invading his pancreas. No symptoms at all except weight loss. And the other thing that's always interested me is hemoglobin levels. We had 27% of patients below a 10-gram hemoglobin level, and also if you pick the patients below 12 grams, there were more than 50% of the patients that had a hemoglobin level below 12 grams. And yet, I bet there isn't a doctor in this audience that doesn't know a patient with pernicious anemia, or gastric polyp, gastritis. And, you know, it's so easy to forget to do the stool and to forget to evaluate for occult blood. More than 50% of the time, these patients will come in with a low hemoglobin level, just quiet bleeding without any symptoms whatsoever. Our resectability rate has improved. I think the last time it was reported from Memorial Hospital was around 45%. Now we were able to resect 55%. So we're seeing patients earlier. We're resecting more patients. And yet this is our overall mortality. At the 1-year level, we've lost about 2/3 of the patients. And at 5 years, it comes out to 7.7%. And that is what's practically going on around the world. Where these lesions were located, the lower third had a 11% survival. But the thing that was so bad is that out of 270 patients, 115 at the time of surgery had practically their entire stomach involved with cancer, with and without carcinoma. And obviously, we had no survivals. That's practically 40% of your patients. The only patients that had an appreciable salvage rate are the patients that have tumor confined to the stomach. And out of 28 patients in this small group, we had 16 for a survival of 57.1%. Once the patients get nodes involved, and there were 107 with nodes involved, only 5 of them lived 5 years, 4.6. And in trying to evaluate what's the best way of treating these patients, The best way to treat these patients for cure or palliation is to do a subtotal gastrectomy. Total gastrectomy should never be done as a palliative procedure, but at times when you're working for cure, obviously it's the procedure of choice. Now, in terms of how we treated these patients, subtotal gastrectomy seemed to be the best. Out of 93 patients, where 19 we could do it and get a survival for a 20% cure rate. These patients probably the ones that had the smallest lesions and the most distal lesions down in the antrum. Total gastrectomy, only 1 out of 10 patients survived. And the patients that had an extended gastrectomy, that means taking out the spleen and taking out the tail of the pancreas and everything else, there were only 1 out of 45 lived 5 years. So in other words, no matter how big you make the operation, it has not helped one bit, at least in our series, and I don't think it's going to be any different in anybody else's series, in terms of gastric cancer. Now, what do you do when you're faced with a patient on the table and he's got a situation that's incurable? Well, if you can possibly do a palliative resection, do it. Because you rid the patient of a fungating, a blood-losing, an appetite-destroying part of his stomach that, by getting it out, will give him more satisfying palliation. So the worst thing you can do is just open and close. If there's any possible thing you should do, even a gastrostomy and gastrojejunostomy, in the long run, gave a better palliation than just opening and closing. Now, this brings up another thing that Dr. McNear and Bowden spent a lot of time on. If you get a gastric cancer recurrence, the most frequent place for that recurrence is in the gastric antrum. Now, most of the time it's either in the gastric stump or in the gastric bed, meaning in the peripancreatic region. So what do you do with a man who comes back a year and a half later and you've done a subtotal gastrectomy and you get a sort of a clinical situation like this? A man's got a recurrence in his gastric remnant. Should you give him up? The mortality rate, the resectability rate, the whole panoramic viewpoint of gastric cancer so poor. Should you put this man through anything further? Well, that case went through this type of resection, a re-resection of his gastric remnant, including spleen and so forth, the tumor at the gastroenterostomy site. Now, are we justified in doing this? Are we prolonging life, or are we just carrying out a technical exercise? Well, there's a study carried out by Dr. Bowden, Bohr, and McNear years ago where they had 57 patients who came back into the hospital with a recurrence in their gastric stump. And they wanted to know, with an aggressive attack upon this gastric stump, could we salvage anybody? Well, out of the 57, 24 of these patients, at the end of the procedure, the surgeon felt that he had performed a curative resection. In other words, he felt that this patient was cured of his cancer. All gross disease was removed. Now, of that 24 cases, they went through total gastrectomy, subtotal gastrectomies, even resections of their anastomosis and so forth. But the surgeon felt that he had cured, at least microscopically, grossly had removed all remaining cancer. 3 of the patients, their nodes were even negative, even though with a recurrence of their gastric cancer. So we thought that we ought to look into this and see what we could find. Now, in the recent study, we find the same thing. Out of 11 patients who came back in with a recurrence of their cancer in the gastric stump, 2 of them lived less than 6 months, 2 of them lived 6 months, 4 lived a year, but 1 lived 2 years and 2 lived 5 years. In the Bowden, McNear, Bohr study, out of the 57 patients, they had 4 long-term survivors. 2 of them lived 4 years and 2 of them lived over 5 years. So you're dead a long time. If you have a patient who comes in, obviously, is terminal. Say he comes in with intestinal obstruction. You have this problem frequently. A man's got intestinal obstruction, and you know you operate on him 6 months before. What should you do? Should you put a tube down and give him morphine and just try to ease him out of his misery, or should you be aggressive? Well, you have to use judgment, of course, because if you feel a man is nearing the terminal state, obviously judgment would dictate not to do anything further. However, here these patients, there were 3 of them, but 1 lived 2 years and 1 lived 5 years with the release of intestinal obstruction. So I think there's a place for being aggressive within reason in patients with gastric cancer. Well, now, I've done nothing but give you a dismal picture of the situation. Can we do anything about it? Well, it's my personal feeling, and this may be heresy, but it's my personal feeling we are not going to do anything further in terms of improving the cure rate of gastric cancer until we start diagnosing these patients before they get symptoms. Over 50% of the patients were treated within 3 months of symptoms, and we're not doing any better than we were 40 years ago. It seems to me that the only way we're going to do anything is to, hopefully, something just came to my attention recently. There's a new test that's come out within the last couple of years by Dr. Kim. And he has found out that the gastric juice of patients with gastric cancer has an elevated beta-glucuronidase levels. And this has now been confirmed by 2 or 3 investigators around the world. Now, whether this test or some other test can be used so we can screen patients with high risks, gastritis, pernicious anemia, something of that nature, to get this group of patients early before they get the symptoms, I don't think that we're going to see much improvement, if at all, in the present way of treating gastric cancer.
Dr. Goldsmith, of what value is mitomycin in treating gastric cancer?
The drug that the Japanese were using so much, and they were very enthusiastic about it 2 years ago. When I came back home and I mentioned it, they said, oh, Dr. Karnofsky, who was a great leader in the field of chemotherapy, tried it years ago, and he said it was just too toxic. Now, whether there's going to be a rebirth of the enthusiasm for this in the United States or not, I don't know.
In our final discussion during this hour, the Mayo Clinic's William H. Remine brings us up to date on the present management of sarcoma of the stomach.
Sarcomatous lesions only occupy 2 to 3%. This is a very small group of patients compared to those who have the straightforward adenocarcinoma. And I don't know whether the sarcoma group are declining as rapidly as the adenocarcinoma group seem to be doing. Just what's causing that, I wish we knew, so we could perhaps apply it to all patients, and then maybe we could begin to get somewhere with the entire cancer problem. There are 2 main varieties of gastric sarcomas. There are lymphosarcomas and Lyle Myosarcomas. The lymphosarcomas of the stomach may mimic gastric carcinoma rather closely, so that the true nature of the lesion may not be recognized before operation. Because the lymphosarcomas have important differences in their responses to radiation therapy and also their prognosis, an accurate and differential diagnosis has to be established. It is also important to distinguish between primary and secondary sarcomas of the stomach. The prognosis will vary greatly between these 2 types of lesions. In lymphocytic lymphoma, on postmortem examination, 40% have been found to involve the stomach, whereas in Hodgkin's disease with lymphocytic leukemia, only 13 to 15% involve the stomach. Now, there are numerous descriptions of sarcomas of the stomach that have been recorded in the literature, and these are classified according to cell type, just as sarcomas are in all other areas of the body. In some cases, combinations of cell types or other variations in the microscopic appearance may make it difficult or almost impossible for the pathologist to assign a definite classification. In general, however, these malignant tumors of the stomach may arise from lymphogenous, muscular, fibrous, fatty, endothelial, or neural tissue, or there may be combinations thereof. The problem of classification occurs much more frequently with sarcoma than it does with adenocarcinoma. Now, let's take the lymphosarcomas first. They comprise about 2/3 of all primary sarcomatous lesions of the stomach. There are 2 main types, the lymphocytic lymphosarcoma and the reticulum cell sarcoma. The lymphocytic type are made up of small, round cells which develop from mature lymphocytes, whereas the reticulum cell sarcomas contain large, round cells which are less mature in appearance. At surgery, there are no demonstrable features that permit you to determine accurately whether one is a reticulum cell sarcoma or a lymphosarcoma. This has to be done in the pathology laboratory. Kundrat is credited with recognizing for the first time that lymphosarcoma can exist as an isolated lesion in the stomach and not be involved in a generalized process such as leukemia or something of that sort. Now, the diagnosis preoperatively may be a bit difficult with the lymphosarcomas as opposed to the leiomyosarcomas. The patient with primary gastric lymphosarcoma usually has a history that is similar to that given by a patient with adenocarcinoma. Lymphosarcomas may occur early or late, but they usually occur in patients somewhat younger than those that have carcinomas of the stomach. A number of these patients have a history suggestive of peptic ulceration, and many of them also have experienced some temporary or partial relief of symptoms. Anemia and blood loss and weight loss also are frequently seen, and vomiting with hematemesis may occur, but much less frequently than with the leiomyosarcomas. The average size of the gastric lymphosarcoma may be larger than the gastric carcinoma, and some authors have reported these to be rather huge. Others, however, think that this is not true and that palpable masses do not necessarily indicate lymphosarcomas. Burnat's found that more than 50% of the lesions in his series were larger than 8 centimeters, and some of them were the size of footballs. The X-ray diagnosis of these, and the röntgenologist may not be able to distinguish between lymphosarcoma and carcinoma. This lesion may be diffusely involving the wall, may be ulcerated, so that the röntgenologist himself may have a bit of difficulty. There is one thing, however, that is thought to be more characteristic of lymphosarcoma, and that is the increased size of the rugal folds. And just why that should be, of course, we have no idea. The findings oftentimes may be those of Leonitis plastica, and may be diffusely involving the wall of the stomach, and it runs along submucosally so that you can't tell just where you should make your resection unless you get frozen section areas right from the edge of the lesion, right from the edge of the resection, and then you can get a great deal of help from your pathologist. If you find some, of course, you have to go back and remove additional areas of the stomach, and these lesions can be removed quite satisfactorily, even though they appear to be quite large. Should the lesion be a lymphosarcoma, even though it is not removable in its entirety, or if you have to leave nodes behind, it still should be resected, if at all possible, because of the marked effect of radiation that we've seen in a number of patients where we've had cures, so-called cures, in patients with very extensive lesions that tissue was left behind, and even in some patients where it was unresectable, we've had some that have lived 5 years or longer after intensive radiation following exploration. Now, the gross characteristics suggestive of sarcoma include the enlarged gastric rugae. Large and numerous and relatively soft lymph nodes may be found immediately adjacent to the lesion in the region of the lymphatic drainage. And a softer feel to the lesion is commonly found in lymphosarcomas as opposed to the rather firm feeling that you get with adenocarcinomas. And I think it's extremely important to try and appraise this lesion beforehand so that you know what you're dealing with. You can give this patient an opportunity for a cure, or at least a long-term palliation or long-term survival. It is important to remember that in carcinoma of the stomach, the operator usually has a fairly accurate opinion with regard to the upper and lower extent of the lesion, but as I mentioned before, you can't be sure with lymphosarcomas. You've got to take tissue from the edges of your resection and ask your pathologist specifically to look at it and make sure that you haven't left some behind if you have an opportunity to do a larger resection and give this patient a better opportunity. The vast majority of lesions occur in the lower half of the stomach, that is the lymphosarcomas, which gives you, again, a good opportunity to do a good operation for the patient without having to go to the operation of total gastrectomy or some other more extensive type of procedure. At the Mayo Clinic, my colleagues and I believe that surgical removal should be followed by radiation in all of these patients, even though you may think that you've gotten it all out. There may be some lymph nodes there that you're not aware of, or there may be some evidence of spread around that you can't detect at the time, and it only takes one cell to make it metastatic, so we feel that they should all have a radiation if we find that this lesion is a lymphosarcoma. In our experience, the overall 5-year survival rate is 65% with this type of lesion. That is, taking them all in one bundle. This experience includes patients with huge growths, patients with nodal involvement, as well as those without gastric spread. We believe that the therapeutic approach to gastric lesions of the lymphosarcoma type should be very aggressive. Resection should be carried out even though residual tumor must be left behind in regional nodes, and a measure of hope should then be extended to the patient. In our experience, even though the lesion requires total gastrectomy for its removal, if it's that big, they can have an opportunity then for a cure. Our overall 5-year survival is 65%, and with total gastrectomy, which was done for the very extensive lesions, then it was 50%, 5 years, and 44% for the 10-year survival. Now let's have a look at the Lyle Myosarcomas. These comprise a very small percentage, about 0.25 of all primary malignant gastric neoplasms. They originate from gastric smooth muscle, but whether the growth is from pre-existing myomas or is direct, it isn't known, and we have no way of proving this one way or the other. The lesion is similar to lymphosarcoma in that it usually occurs with equal frequency in both sexes and at a somewhat younger age than does carcinoma. Perhaps the most significant symptom is bleeding. This occurs in approximately half of the patients that have this lesion. The blood loss may be either massive with hematemesis and melena, or it may be chronic, recurrent, and small in amount. Significant degrees of anemia may be noted, and ulcer-like abdominal distress occurs in most of the patients. It may be somewhat different from that with lymphosarcoma or adenocarcinoma in that it may be colicky and intermittent or persistent, either one. The distress is not diagnostic, and it is usually located in the epigastrium, although it doesn't have to be. Occasionally, a large palpable mass may be noted on physical examination. And the most useful diagnostic procedure, of course, is X-ray examination of the stomach. The X-ray will reveal some type of abnormality in about 90% of the patients that will give you a clue as to what the nature of the lesion is. There may be some difficulty in distinguishing a Lyle myoma from a Lyle Myosarcoma, although the latter usually are considerably larger. They can resemble one another quite closely, however, in the small stage, the early stages of the Lyle Myosarcoma, but seems to come most often from the anterior and posterior wall of the center portion of the stomach. This is of help because you don't have to do as extensive a resection for leiomyosarcoma as you do for a lymphosarcoma or for an adenocarcinoma, because they don't tend to spread to nodes as the other lesions do, but more by direct extension. So if you can see where the lesion is and you can get around it, you can salvage some of the stomach. Our usual reconstruction with a partial gastric resection, it's a Hofmeister-Pallier modification, and I might commit a bit of heresy here and say that it doesn't make any difference. You can hook it up anacolic or post-colic. You find this is like lots of other things in surgery that are developing into the surgeon's choice. It depends on where you were trained and who you were trained by and that sort of thing, because they're about equally divided throughout the country among surgeons, whether you put it behind the colon or in front of the colon, and usually in a situation like that, you find it really doesn't make a great deal of difference. I use them either way, whichever seems most convenient and easiest to do with the particular type of patient that I'm operating on at that time. After total gastrectomy, if we should happen to have to do one, this is the procedure that we found to be the most effective in our experience in studying some 400 and some total gastrectomies for all types of lesions. This is the one that gave us the least morbidity, the least mortality, and the best post-operative effect, that is, with the least amount of complaints. With a straightforward esophagojejunostomy and end-to-side procedure with a jejunojejunostomy below it, I have modified this quite a bit in recent years in that I like to extend it up and get a much wider opening so that you get a nice pouch where food can come in and mix with bile and pancreatic juice so that you can begin to get a fair degree of mixing before it passes on down. And this, I think, has worked out very satisfactorily for us for the most part. But we feel, in conclusion, then, that lymphosarcoma and leiomyosarcoma, even though they're very rare and they may appear to be quite ominous at the time of the examination with X-ray and palpation of a large mass, these people should be given an opportunity for surgery because, certainly in our experience, and that's been reported from other places, the opportunity for a cure is still quite good, even with these large lesions, and particularly with the lymphosarcomas. They can receive X-ray therapy afterwards and expect to get quite a long bit of palliation, if not a cure. Certainly when the tumor can be removed completely at operation, then the prognosis is quite good.
A question, Dr. Romine. Should the spleen be removed in all cases of malignant lesions of the stomach?
Yes, I think the spleen should come out in all cases of malignant lesions of the stomach, whether it's carcinoma, lymphosarcoma, or leiomyosarcoma, because I think the nodes in the hilus of the spleen are very important. The lymphomas occur in an area that might drain to the nodes in the hilus of the spleen. Certainly if 30% of the carcinomas are found to have positive nodes in the hilus of the spleen, this would be very important. Now, In the Lyle Myosarcomas, you might want to hedge a little bit because they don't tend to spread to nodes except by direct extension, but that would be the only place where I would give very much on it.
Thank you, Dr. Amine. And this concludes the 12th issue of Audio Digest Surgery, Volume 17. Your next issue will be mailed to you 3 weeks from now, rather than the usual 2, to spread your 24-issue subscription over the 52-week calendar. Until then, Doctor, thank you for listening.